Okay, perfect. So as people continue to flow in, we're just going to get started here. So welcome back, everyone. I hope you had a really great lunch. And yeah, we're excited to continue with today's sessions. Just a reminder to everybody again, just please remember to use the chat function or raise your hand if you have a question during the Q&A portion. At the end of the Q&A, if we don't get to your question, as long as it's in the chat, we'll pass it on to our presenter, and yeah, we can go from there. So let's get started. It's my pleasure to introduce our next speaker, Dr. Pavlos Bobos, an expert in the field of musculoskeletal health. Today, they will be speaking on optimizing exercise therapy for knee osteoarthritis. Following the presentation, our panel discussion today will include Benjamin Norman, Laura McLacken, and Kevin Thorpe. So each one of our panelists brings valuable insights into our discussion. Yeah, and what I will do now is stop sharing my screen, and Dr. Bobos, you can go ahead.
Perfect, thank you. Okay, let me share my screen. Can you see my screen? Perfect. Okay, thank you everybody for coming today. I would like to thank the organizing committee as well the Pragmatic Trials training program for giving me the opportunity to present my protocol. So today my protocol is about optimizing exercise therapy for knee osteoarthritis. It's a Bayesian multi-arm Zeland design randomized controlled trial. And I will present the elements of feasibility and some clinical effectiveness data. So before I start, I would like to disclose that I am a faculty at Western University. I'm an assistant professor. I don't have any conflict of interest. I have received grants from the Canadian Institutes of Health Research, as well as the Arthritis Society of Canada, and I served at the Ontario COVID-19 Science Advisory Table as a research associate. And I'm a Cochrane member, and I serve also in two peer-reviewed journals in the editorial board. So the research question that I'm going to present today is about a trial that seeks to determine feasibility and preliminary clinical effectiveness for targeted exercise interventions compared to an attention control in individuals with knee osteoarthritis using a multi-arm Bayesian Zeland RCT design. Now, when we think about knee osteoarthritis, there is no cure actually for knee osteoarthritis, and the burden that is associated with knee OA is actually very large. And as we can see in this graph here about the burden of OA, there is almost 500 million people as we speak that experiencing knee osteoarthritis, and this is projected to be increased. Again, the prevalence rates are being caused by different variations depending on population aging or growth. But as we can see here also that the marginalized people are being affected the most. Now, what is osteoarthritis? So osteoarthritis is mainly osteoarthritis is a progressive degenerative disease and is characterized by destruction of articular cartilage. And the hallmark symptom of OA is pain. There are multiple mechanisms and risk factors that are contributing to knee OA, with aging, for example, a non-modifiable risk factor, or sex. Females are affected the most. And there are other lifestyle factors that probably are contributing to the mechanism of injury. So it's a multifactorial, let's say, progressive disease. And again, as I said, there is no cure, and the interventions that mainly are now in the literature are targeting for symptom management. Now, let me set the stage why perhaps this trial is needed. And I have to go back in 2019 because Verhagen and colleagues actually they published in Osteoarthritis and Cartilage a brief report about, and they were asking whether we need another trial on exercise. And they made actually a very bold statement after analyzing 42 studies and around including 7,000 participants. So what they concluded, and they said that exercise is not only effective and clinically worthwhile, but is unlikely future trials to change that conclusion. And as you can see here, they have a funnel plot which they conclude there is no clear publication bias present. And today I'm coming to you and I'm saying that I'm going to present another exercise trial, but let me justify why this is the case. So what I first did, I revisited the publication bias and small study effects by Verhagen and colleagues. So I felt that the statement was too bold, too good to be true. So I actually analyzed the funnel plots to see if there is indication of publication bias. And this was one of the funnel plots. But the interesting thing was when I analyzed the small study effects, and I test the small study effects with Egger test, we see that is statistically significant. So there was some kind of evidence that the statement that they made was actually based and was driven, I would say, with small study effects. So the next step, what I was going to do is I was testing the hypothesis of Verhagen and colleagues. Perhaps, you know, if there's definitive evidence that exercise is working, and if we remove all the small study effects, if we analyze all the trials without the small study effects, meaning the small trials, and we analyze only the higher quality trials, probably we will get the same conclusion. And what we did, and this study is currently under review, we actually had a big network meta-analysis to compare the effectiveness of different exercise modalities in patients with knee and hip OA. And what we found was actually really surprising because we analyzed different time points, 6, 12, 24 weeks, and 52 weeks. And as we show here in this forest plot, there were only one intervention with certain components, including education, strengthening, and flexibility, that there were some evidence that is really working, but nowhere near the definitive evidence that Verhagen and colleagues, they said. So there was high probability for this type of intervention actually to work, and it was ranked first across all the time points. But as you can see here, all the other components in the exercises modalities, they didn't actually make a difference when compared with usual care. So the problem and why we need a new trial. So it seems that the current osteoarthritis trial evidence is driven by small study effects. And then the second thing that we found in the network meta-analysis is we don't know what components of exercise are effective or not. So what we try to do with this big network meta-analysis, we're trying to actually explain what kind of components they used in these different interventions. And of course, there's other problems if we think about not all patients are responding to exercise, and the same can be said with pharmacotherapy. So we need to actually explore the reasons why some people are responding to exercise and why some not. And the last thing is that the current RCTs are plagued with high risk of performance and detection bias. And this is actually an inherent limitation that we have in the rehab trials. We cannot actually effectively blind participants and personnel because of the nature of the intervention. So how we're going to address that? So first of all, how to address the components of exercise. Along with the big network meta-analysis that we're doing, we're conducting a separate study and we're trying to identify the additive effects, or let's say the best components of the exercise interventions. Because if you think about the exercise intervention is a multimodal one, it's not just one component, there are several components of the exercise. So Susan Freeman actually described that kind of methodology, how you can use a component network meta-analysis to identify the most effective components. And we're trying actually to identify those components before we run the trial. Now, just to remind you, the trial objectives, the primary objective for the trial that I'm presenting today is to assess feasibility of conducting a larger pragmatic RCT, and to assess feasibility, we evaluate the recruitment rate, retention, and adherence rates. Specifically, the feasibility will be measured through the proportion of participants completing follow-up at 3 months. Now, the trial design is a Bayesian one, and I'm going to explain what I mean by Bayesian. With a modified Zelen design, pragmatic RCT, for randomization, we will use a central web-based randomization software with allocation ratio 1:1:1 with random permuted blocks. We will stratify by sex and disease severity. We will use intention to treat, and then per protocol analysis for adverse events and serious adverse events. Now, let me explain what is the Bayesian approach and how is that compared with the traditional approach, the frequentist approach. So the concept of frequentist approach is based on repeated sampling. And again, if you think about, we know nothing when we conduct our hypothesis testing, we know nothing about the experiment before, so we don't have prior information. With the Bayesian approach, we do have prior belief, we do have prior information that we can incorporate. And as you can see here, that blue line that looks like a distribution curve, if we combine that with the likelihood function, which is represent our new data, we get our update belief or the posterior distribution, which is the red one. If you think about that, the frequentist approach has unknown but fixed parameters, I would say advantage of the Bayesian approach is that we can calculate that uncertainty and all these parameters using probabilistic theories. Now, the Bayesian approach has been criticized in the past about how we select that prior information, and there are actually some papers out there, that this one that came up from a Novartis statistician, how you can robustify the prior information that is coming from historical data. And that also present an advantage because you can increase the power of the trial without recruiting a lot of participants because you're using the sample size, you're using the prior information for the sample size calculation. So really that gives an advantage, especially is if there is a budget issue and you need to recruit less people to achieve, let's say, 80 or 90% power. Now, I want to explain what is the modified Zelen design and why we're using it in this trial. So as I said, it will be a modified Zelen design. So usually in the traditional trial, as soon as the participants, as soon as the participants are randomized, identified, before you randomize, you're seeking consent. With the modified Zelen design, technically you're requesting consent after randomization, and actually after the last follow-up outcome, there will be a disclosing interview to ask consent to use the data. And why we're doing this? So again, if you think about what I said about the problem that we have in rehab trials, that we cannot actually blind participants and personnel. So that will be an effort to see if this is successful or not. Now, in terms of eligibility criteria, if you think about participants with knee osteoarthritis, we're going to recruit participants that they have primary type of knee osteoarthritis. There are different types of knee osteoarthritis. The recruitment will be based, generally speaking, on communities. And what we're going to use clinical criteria, not even radiographic findings about the knee OA. And again, in the literature, it has been described many times that radiographic findings, they're not associated most of the time with symptoms. So we will use the NICE criteria for including people, which is joint pain and again, early morning stiffness, less than 30 minutes. Moving forward regarding interventions, again, our network meta-analysis as well the component network meta-analysis, we will select the interventions that they have the highest ranking and the components actually that are really working, they seem to working the best. And this will make the two treatment arms compared to an attention control. And let me explain what I mean with an attention control. So usually when we conduct rehab trials and physiotherapy exercises, we have an educational component. So the patients will receive information about NEOA, general health, pain management strategies, but without specific exercise prescription. So the active component actually of the exercise will be missing. And again, it will be like a supervised interaction, and patients will attend these sessions. It will be a similar length and structure as the exercise groups, but they will engage in low intensity activities, discussions, or placebo stretching routines. Again, as I said, the active component of the exercise will be missing from the comparator group. Now, in terms of outcomes and measures, so what we're going to do is we have the primary feasibility outcomes that will be assessed separately, and I'm presenting those in table 1. There will be progression criteria to assess feasibility based on traffic light approach. So we're going to check recruitment, average per month, intervention fidelity, adherence, acceptability, retention, Zelen acceptability, blinding success, and outcome completeness. And again, whether this kind of progression criteria fills in green zone, probably we will proceed with the definitive trial. If they will fall in amber zone, probably we'll proceed with changes. If something falls in the red zone, probably will not proceed with the full definitive trial. Now, I want to highlight that there will be collected also clinical outcomes such as pain intensity, physical function, and health-related quality of life. We will record also the physical activity using ecological momentary assessment platforms and wearable technology, and we will assess also adverse events. And regarding the sample size calculations, the sample size will be based on the primary outcome of complete follow-up using confidence intervals. Again, for calculating sample size in pilot trials, we will aim for 90% follow-up, but we will consider the trial successful if we can achieve at least 80% for primary outcome. And again, to achieve a margin of error of 10% with 10% added for attrition, approximately we will require 60 participants, like 20 per group, to achieve successful follow-up. And again, this requirement of 20 patients is consistent also with general guidelines for pilot RCTs. So we can have parameter estimation, standard deviation, correlations for the primary outcome. And it will be based also on the traffic light approach to evaluate the feasibility outcomes that we have adopted. In terms of challenges and current status, I just wanted to say that there is a challenge again with rehab trials and the nature of the study intervention, considering that this is exercise. The inability to blind therapists and participants have been described a lot in rehab trials. So we're trying to tackle that using the Zelen designs. And again, as a third point, there is also the problem that involves the randomizing participants before informed consent is sought. So how you're going to involve patients without asking consent in the start, it can be really challenging. And again, in terms of progress, the protocol is almost ready for registration and submit also for ethics approval. The component network meta-analysis is under review, so we will get feedback from peer reviewers regarding the exercise modalities. And these are my references that I used today. And thank you very much. And I'm looking forward to receive your questions.
Awesome. Thanks very much, Pavlos. I will go ahead and share my screen here. Just one quick second. Okay, so there's a few comments in the chat, but before we go on to the chat, we're just going to introduce our panel and have a panel discussion first. So as far as the panelists go, if you could please introduce yourself briefly before asking your first question, that would be great. And Benjamin, we'll start with you.
Great, thanks, Joe. Yeah, my name is Ben. I manage a research lab at the Alberta Children's Hospital in Calgary. We focus on interventional research for children with mobility impairments mostly. Thank you, Dr. Boas, for that talk. I thought it was really interesting. My first question, I'm wondering if this is kind of the first feasibility design proposition for this type of therapy for knee OA. Have the studies that you referenced in your meta-analysis, have they reported anything on feasibility at all? And if so, what does adherence look like in those studies? And ultimately, how did you land on 80% being the successful feasibility measure?
Yeah, thank you very much for your questions. First of all, the trials in my network meta-analysis, especially those that they have more, let's say, prominent effects, treatment effects, were actually trials that were run back in 1997 and 1999. If we go again and think about 20 years later, someone came up with a brief report and say exercise working, and not only working, we have strong recommendations from the clinical practice guidelines. We have a problem there, because the problem that we have as therapists, and I'm making an introduction now, and I'm wearing now my clinical hat, is that when we say that exercise is working and we have strong recommendations, then the question is, and the patient comes to us with knee OA, is okay, what kind of intervention I'm going to use? Because exercise can be a lot of things. Can you describe like strengthening? What type of muscles, for example, can you target? What is the intensity? What is the frequency? So all these pieces from all these trials, they're actually missing. So you cannot replicate the intervention that is coming from these trials. And this is a huge problem, right? So that's why I'm proposing another trial. And again, I'm not sure if I answered your question about the first part, but the second part about the progression criteria is based on how many patients actually we can recruit per year in the Western area. It will be a single site. So we came up for a reasonable, let's say, progression criteria, 6 to 8 participants per month. I'm not sure if there's any literature around that and how you can standardize that, but we're based on basically how many patients we have annually and we can see, and then this is how we determine that. Yeah.
Great, thank you.
Perfect. Thanks, Ben. And Laura, we'll go to you next.
Sure. Thanks, Joe. Hi, Dr. Bobos. Thank you for that presentation. That was quite interesting. My name's Laura McLagan. I'm an associate research methodologist at ICS. I work in the fields of neurodegenerative disease health services research. So this, I must admit, is outside my area of expertise. So feel free to forgive me if my questions are a little bit off the mark. Just wondering a little bit more, focusing sort of on the patient perspective. How you sort of briefly mentioned it in your answer to the last question, how do you plan to recruit the patients? And do you feel the patients you'd be recruiting, are they generalizable to the broader population of people living with OA? And then just like a second part to the question is just about the follow-up. Like, do you anticipate this follow-up will be burdensome for patients? Like, is there going to be a lot of in-person follow-up required, or is it virtual? Both? Just wondering about your plans for that.
Yeah, that's an excellent question. So I think what we're going to do is we'll use also the Arthritis Society, which is a nonprofit organization, and they have a huge list actually of patients that they're going in the communities, and there are people that they actually have knee OA and they are seeking treatment. I'm not sure if your questions pertains to how we're going to recruit based on the Zelen design. And if I'm going to answer that, so the way I'm not sure if you're asking about the procedure, the way you approach the patients, and there is also with Zelen a level of deception, of course. So when you approach these patients, you're saying, you know what, we're going to do an observational study, and there are going to be some kind of follow-up measurements to do the natural history of knee OA. So this is the plan, how we're going to recruit the patients. And again, in the end of the trial, we're going to disclose that, hey, you know what, you were part of a randomized trial. Do we have consent to use your data? So I'm not sure if I answered your question completely. And then the second part, sorry, what was that? If you can.
Just wondering about the follow-up. So I know you have
Yeah.
your follow-up's quite frequent. Like, is that going to be in person? Can it be virtual?
Yeah.
Do you think that's burdensome for patients who might be enrolling in the trial?
Absolutely. So what we're doing actually now, and some of my students are working that, they're taking actually the effectiveness of different remote interventions that can be delivered remotely. And from the preliminary data that we have, it's pretty much we have similar effectiveness with in-person and remote interventions, especially for exercise trials. So we are considering also to use a hybrid model in terms of in-person, but as well remote delivery.
Thank you. That's great.
Perfect. Thanks, Laura. And Kevin, let's go to you next.
Hi, Pavlos.
Hi, Kevin.
So I'm Kevin Thorpe. I'm an associate professor of biostatistics in the Dalla Lana School of Public Health, University of Toronto. I'm also now currently the scientific lead for clinical trials design and analysis at Sick Kids. And I suppose noteworthy with respect to the pragmatic trials is I was the lead author of the 2009 Precy paper. So my questions are going to focus a lot more on the methodologic aspects, which I guess is why I'm here. So I guess I'll start with, you stated that this is to be a pragmatic trial, but I've heard so far, I guess, two things that are slightly less than pragmatic at this point. Single center, of course, it is a pilot study. And Laura referred to a reasonably intense follow-up, which also, when you get a deviation from standard visit schedules and that kind of thing, you lose the generalizability you hope for in a pragmatic trial. So my question is sort of what then about this study or trial in your mind qualifies it or makes it a pragmatic trial?
Yeah, that's an excellent question. Thank you, Kevin. So first of all, is about the eligibility criteria. We loosen up a lot the eligibility criteria, how previously OA trials actually recruiting people. If you think about X-rays, diagraphic findings, MRIs, inflammation probably in the knee. So we're based that in a completely clinical criteria that anyone can ask some people, do you have joint pain and early morning stiffness? Probably you're qualified to get into the trial. As for the single side, I was having the thoughts about using a multi-site as well from the pilot. I would say it was mostly like a budget issue more than actually and a decision to use a single site. But I guess using a multi-site, it will be more of a pragmatic site. I totally agree with you. The Arthritis Society that we're going to recruit, they do have different communities, but it's only, let's say, mostly based in Ontario. So I'm not sure if that qualifies as a multi-site. I just want to be realistic here. This is something that we can discuss. And then what was the other question about the follow-up? Again, we want to see whether the intervention effects probably they have some lasting effects. Most of the trials they have done 12 weeks, but we see as we go 6 months and 12 months, probably the interventions effect are fade off. But given that we analyze so many trials, the problem that we have is that probably the adherence rates are very low. So it's less than 40% in the majority of the trials. And we have also, I would say, major dropouts as we move like across to 1 or 2 years. So we're trying to address that issue, but I'm hearing you what you're saying, that it's going to be less pragmatic with the intensity of follow-up measurements.
Okay, thank you. I guess we'll get another round of questions because I've got more.
Absolutely. Thank you, Kevin.
Perfect. So I'll open it up to the panel as you go before we move on to our audience discussion. So with Ben, Laura, and Kevin, if you have any more questions, comments, please feel free to discuss before we move on to our audience discussions.
Sure, thanks, Joe. Maybe if we just circle around, if that works. Kind of building off of Kevin's question, and Dr. Bolwas, I know it might be a big picture thing now, but I think it always helps to kind of consider these things well in advance. But what kind of pragmatic considerations, you alluded to a couple with Kevin's questions, but what kind of pragmatic considerations would you need to consider when the study eventually does go multi-site?
Again, thinking about how many probably exercise experts we're going to use, like physiotherapists, right? And they will seek out probably healthcare professionals that they're out in the community and they deliver the interventions in the community. With the mode of delivery, of course, it will make it more pragmatic. Again, it won't be something that would be just a standard way of delivering the intervention. So we're trying to address accessibility issues that they had, how the intervention is going to deliver it. If you're asking about the intervention, sorry, I'm not sure if I answered your question completely.
No, that's okay. I mean, it was pretty broad, but yeah, I think that was like my thought was kind of the staffing requirements at sites to help carry out this which you touched on. So yeah, that's great. Thank you.
And again, I just want to clarify when we talk about remote interventions, they still maybe be some accessibility issues because many people actually that they are in the communities, they may don't have access to internet or equipment that probably they can share screens and they can do remote sessions with healthcare professionals. So that's another issue that we're trying also to tackle from a pragmatic perspective.
Yeah, that's a great point. Thank you.
Yeah, I can jump in with another question. So Dr. Bobos, I think in your presentation and certainly in your protocol, you alluded to the choice of potentially, I think, 2 intervention arms, if I have that correctly. So you'd have 2
Yes.
active arms. And I understand that your network meta-analysis is ongoing and will help you select those. Just wondering, like, what's the rationale behind having 2 intervention arms? Why not just one? And if you were to kind of think in the future, what do you think your exercise intervention would look like?
Yeah, that's an excellent question. So I didn't present the results of the component network meta-analysis because it's under review. But what we're getting from this analysis is that there are different components actually that they shape 2 different interventions, and they're very close together that I'm not sure which one I want to pick first, especially if they're matching so much in terms of treatment effectiveness. So it's difficult for me to say, you know what, there has to be some kind of shared decision making among the team members, which one performs the best. But again, when they are so close together, I would say, you're wondering whether I should pick one versus the other or both of them actually. So that is the debate that we have at the moment. And again, that's an excellent question. I wish I could pick one, but at this point I can't. That was the rationale that why we picked and I selected, for example, 2 treatment interventions.
Yeah, because I guess I'm just wondering, like, given this is a feasibility, the primary outcomes are feasibility related. You're not looking to distinguish the effectiveness between those 2 active interventions. So just kind of wondering whether there's an opportunity to simplify here, if possible.
Yeah, absolutely. So there will be no effectiveness outcome like any analysis because the trial will be underpowered 100%. But what we're trying to do also, there will be qualitative interviews in the end with the patient. So we're trying to optimize also the interventions and everything because this will give us the opportunity to switch, to the definitive trial later. Again, if through the patients and the patient's voice that will come from this qualitative interview in the end, there is an opportunity actually to combine some of the elements of the 2 active treatments. That will be great, and probably we'll move forward with one intervention.
Yeah, that makes a lot of sense. Thank you.
Thank you for the question.
Okay, I've got another one. Just trying to decide what I'm going to ask. So I guess I'm kind of referring to what I saw in the protocol that I had to look at, and there was, once establishing feasibility, the question was whether it's going to justify what was put as a phase 3 confirmatory trial or a phase 4 pragmatic trial. I guess in my thinking, I would have thought a phase 3 trial would have been more of an explanatory trial. And so the thing I'm kind of wondering how you would operationalize, if you're doing a feasibility trial that's pragmatic and you're wanting to roll the data in to a subsequent larger trial, the goal is the designs of those 2 trials have to be almost identical. Otherwise, you really cannot combine them. And if one target is more explanatory and one target is more pragmatic, how are you planning on making that decision and reconciling those 2 distinctly different philosophies?
Yeah, that's a great question. So I think the idea is to have not an adaptive design. So we're not actually going to switch the pilot trial immediately to a definitive trial. The idea is to collect whatever data we can within the pilot feasibility trial and then optimize it so we can make the best possible decisions to have it as pragmatic as possible. I would say, and there is also in the literature that's saying the Zeland design probably avoiding those disappointment effects, especially if you know that probably that you're randomized in the control group. It makes me more pragmatic because there's no randomization, at least in the first stage of the when you randomize the patients. So to your question, Kevin, what we're trying to do is complete the feasibility trial and then see how we can run a pragmatic trial based on the information that we get from the feasibility one. I don't think there is an opportunity here to switch it to an adaptive and make it, run completely to a definitive trial, because as you said, things can be identical, so you can switch from pilot to, let's say, 3 or 4 phase clinical trial.
Okay, thanks for the clarification.
Perfect. And there was a comment in the chat from Stephen Kucher, who actually just had to run now, but he was wondering which prior did you use for your sample size calculation? Is there consideration for using a range of priors in the analysis? And if yes, what are the implications on the sample size estimation?
So we didn't use any prior information. We're trying actually to have the parameter estimation. The prior information we derived from the network meta-analysis historical data. So I'm not sure what kind of prior is referring to. Perhaps I said something in my talk that was not very clear, but I didn't use any prior, unless he's talking about what kind of prior I use in my Bayesian network meta-analysis.
Yeah, it might have been referring to your Bayesian network meta-analysis there. From the question, yeah, and Stephen had to run off. So potentially, if you'd like, you can follow up with him as well. The questions, Dr. Bobos, will be given to you there.
Okay.
And then I saw Gordon as well had a comment to encourage everyone involved in RCTs to use the term masking, not blinding.
And I fully agree with that. And that's an excellent comment. Yeah, masking is more appropriate term.
And there's a link there to an article as well.
Yes.
Perfect. So if the panelists have no other questions, comments at this time, we can go on to our audience discussions as well.
I think I have one more.
Perfect. Go ahead,
Well,
Kevin.
I have more than one more, but I'll just sort of raise, I think, a somewhat pertinent one. So in the statistical analysis section, it was meant in the protocol, it was mentioned using both frequentist and Bayesian approaches. And I guess, especially if you're wanting to reuse data, there's serious consequences of trying to do that in a frequentist way. Whereas you have a lot more flexibility with Bayesian, you don't have a traditional type 1 error problem. So part of the question is sort of why do the frequentist at all if you're wanting a Bayesian analysis? And also, I guess, related to the Bayesian analysis, you talked about non-informative vague priors for all of your parameters. I wondered if you'd also consider weakly informative priors, both pessimistic and optimistic, to actually understand the impact on your posterior probabilities.
Yes. So we did consider within the team some of the prior information that is coming. Some of the papers, like Turner et al., they are describing how what kind of prior information we can use. So we can use actually vague priors or weakly informative priors or other priors, and we can do a sensitivity analysis and see how these priors, they do affect the posterior distribution. So this is something that we have in mind. As for the frequentist information that is there, I do agree that it was a combination between the Bayesian and the frequentist, and the information that we have from the statistician was actually to use frequentist as well. So I'm not sure, like, and I know, Kevin, you're a statistician. The information probably that will come from the Bayesian, the statistician wanted to see if with the frequentist approach will be very different. If you ask my opinion and my little bit experience with Bayesian since 2020 that I'm working, probably they will be very different compared to each other.
Yeah, I guess where I am in life now, the older I get, the more Bayesian I seem to be becoming in my head.
You're not.
And the less enamored I am with traditional frequentist Neyman Pearson theory.
Yeah.
And it seems a shame to me to wreck a perfectly good Bayesian design with frequentist analysis.
Yeah, absolutely. I agree with
when
that.
The Bayesian framework is so rich and you get the kinds of information out of it that you really want to get without leaning on awkward interpretations.
I agree, and the probabilities are more intuitive to interpretation. And again, you can estimate parameters of uncertainty, like the probability of reaching, for example, them between MID. So there's a lot of things that you can do, and the freedom that you have with Bayesian. I totally agree with that.
Perfect. Thanks very much, Kevin. And Manali, I see you have your hand up. You can go ahead.
Thank you. Excellent presentation, Dr. Bobos. I have a question about Zelen design. So the flow, more on patient flow diagram, how do you see, so patient coming into the clinic and then you recruiting them for the RCT, however, they do not know that they are getting recruited. There would be certain expectations from the researchers, right? So you coming in, and then we expect you to be there on every Sunday for this particular exercise, and then they are compared with this control group, which doesn't have, probably an active control group doesn't have that exercise component, but more on nutrition or education type. So that's where, so how would you, because if they're not getting informed, if you're not getting the informed consent, these patients are getting randomized, how do you see them getting recruited for, what would you, so my question is it feasible? If we do not have a consent, can we just go ahead and talk to these patients? Okay.
So just to clarify, there is an informed consent, but it's not the real one. So I'm not sure if I said that there is a level of deception that is coming. So when you approach those participants, you say that, we're doing an observational study and, you're seeking consent technically for that observational study. There's no mention about RCTs and randomization. And to your question, this is why I'm checking like the feasibility, right? So whether the Zelen design is acceptable or people, they're declining to give consent to use their data, it's part of the feasibility trial. And whether we can mask patients and personnel using this design effectively. So it's all part of the feasibility trial. So to say the truth, I don't know the answer, but I have checked also in the literature big NIH trials using Zelen's design. We're talking about 600, 700 people, I think, if I remember correctly, Stability 1 or Stability 2 trial, they randomized 1,200. Only 1 or 2 people declined to use their data. So I'm not sure if that will be the case here, and probably that's a big extrapolation that is coming, from a surgical trial. But I don't see why we cannot test it. But to answer your question, I don't know the answer. That's why we're using the feasibility aspect of the trial to see how successful the kind of questions you have are.
Perfect. Thanks very much, Manali. Victoria, we'll go to you next.
Hi, we're at the coordinating center here. Can you hear us?
Yes, I can hear you.
Pablo's very, very nice presentation. What I wanted to ask you was, what type of intervention effect are you trying to determine? So what do I mean by that is the following. Some interventions don't require much participant participation in receipt of the intervention. You just provide it and they receive it. But here, when you're talking about exercise, you need quite a bit of motivation to do exercise, particularly a large amount of it. So are you trying to estimate the treatment effect in all people, regardless of their motivation or not? Or are you trying to estimate the treatment effect in people who are motivated to do exercise? Now, what is the effect of that exercise on their OA outcomes? Because I kind of see this as a challenging consideration. Like what, and they're both important, because if you have now the patient in front of you with OA and they tell you, I don't want to exercise, and you didn't understand their motivation to exercise and you randomized them beforehand, and then they don't exercise, that's still relevant, but it's a slightly different question than my inclusion criteria where people were motivated to exercise and then I offered exercise versus not, and I saw the outcomes. And so just was interested in your thoughts there, because I find this kind of a bit of a thorny issue with these complex interventions that require a lot of participant activity in the intervention.
Yeah, and this is the case with all the exercise trials, I would say. Participants needs to be motivated to do the exercise, and that's why also we have a low adherence in terms of exercise. Probably if you are in pain and I'm telling you to do exercise, and maybe certain exercise, they also amplify the pain somehow, that also will create some lack of motivation. To say the truth, I don't know the answer there, but if we're thinking about an explanatory trial and we're recruiting only patients that they're motivated to do exercise, I was thinking that probably we'll take that aspect of the pragmatic trial out because we're actually filtering out participants, all the participants that they're in the community and they have NEOA. But I can see how motivation can play a role in terms of exercise. I'm not sure if I understand your question correctly, what type of effectiveness intervention you're asking. So if you can repeat that for me.
Yes, thank you. So in terms of your inclusion criteria, you don't, I understand correctly, you don't have their interest in exercise, motivation, because of pain or other reasons. So then when you estimate the treatment effect of the exercise, and suppose you show that it's neutral. In terms of now delivering care, I guess that's important information. Then if I just deliver this, it's neutral. But if a large proportion didn't want to exercise, but there are a few selected who wanted to exercise, and if you had your inclusion criteria instead, like I selected people who were motivated to exercise, and then you get an estimated treatment effect there, that then applies to the patients in your practice who are motivated to exercise, which is different than the estimate of the treatment effect in everyone where a fair proportion don't want to exercise. And they're different questions. I'm not saying one's more relevant than the other, but I kind of see this bit of a tension in terms of your inclusion criteria of including people who are interested and willing to exercise. And in this kind of design where you're not really ascertaining that beforehand, and they're not even aware that they're being randomized. Is your estimate of treatment effect just all comers of OA? And then if I'm caring for OA, that doesn't answer my question. If someone's interested in exercise, if I offer it to them, they get better. Right? And I'm not sure if I'm being clear. Like, I'm not saying there's one question is right or wrong, but I think they're slightly different questions.
Yes, I agree. They're a little bit different questions. I don't know what is the best answer here to your question, to say the truth. I would say for someone, and again, I shouldn't base that on my opinion. From the exercise trials probably that they haven't done, and given the network meta-analysis that we did. So we show large people, especially the network meta-analysis, have more than 100 people per arm participated in trials. And unless I am mistaken, none of them actually was asking in the inclusion criteria whether you are motivated to do exercise or not. So I don't know the answer to your question, and I'm really sorry about this. But that's an excellent comment also.
Well, finally, one thing you could consider if it didn't disrupt your trial flow is if you ascertain this at baseline, maybe that's an interesting subgroup analysis.
Yeah, absolutely. Yes. Yeah, absolutely. Yeah.
Okay, perfect. Thanks very much, Amit. And Gordon, you can go ahead.
Thanks for your talk and introducing us to your trial, and especially introducing me to modified Zelen design, which I'd never encountered or heard of. But as a psychologist by training, or a experimental psychologist rather than a clinical one, I've got some experience in deception and doing studies where you deceive your participants. Given this as being RCT, and I'm not sure if I followed completely what the interventions are going to be, given some of the questions that have happened, but I'm sure I heard you say something along the lines of that made me think that some of your interventions are effectively sham and are not actually going to be efficacious in any respect. And I wondered how ethical you think that will be, given that you have maintained that you don't think there's going to be, you don't think the evidence that says that exercise is effective anyway is convincing. I guess that's one side of the ethical issue, but I think this will be tricky, and presenting it to an ethics committee. So I just wonder if you could say a bit more about how you're going to deal with that.
Yeah, thank you so much for your question, Gordon. If you think about the intervention, and again, the bold statement, the paper that presented from Verhagen, like the statement that exercise was working was really bold. So if we take into consideration in front of the ethics committee that, you know, exercise is working and you randomize some of the patients to something that is working versus something that probably, you know, is a sham and not working, there's not an active ingredient there. That would be the case. But what we're presenting to the ethics committee is actually that exercise. And again, I am a physiotherapist from a background, right? I may be biased, but what I saw is when you take out the small study effects, it's far from definitive conclusions that exercise is working. It may not working actually, because when you analyze those part of trials, there's not definitive evidence that is working. So the argument actually is you're testing some interventions that you don't know that they're working or not. I'm not sure if that answered your questions a little bit, or if you want to add something as a follow-up.
I guess it touches again on maybe something Laura was saying, that you've got your two interventions, and I forgive me for, I think I must have missed this in your presentation, but what is the control? Maybe that would, if you could refresh my memory on that, that would help.
Yeah, it will be attention control. So usually there are also other big systematic reviews and Cochrane reviews that say the educational component of the intervention, like, you know, and then
Okay.
the question is what type of education probably you do, because every trial, depending on what country you are, the education component can be different, right? But the educational component can be effective as well, not only, you know, the exercise. That's why
Okay.
there are several other components there. So I would say the participants and the argument, the line of argument there is they are being randomized to something that potentially is working for both of them, not actually that is not working, but the one won't have the active component of exercise prescription and supervised prescription exercise.
Okay, thank you.
Thank you, Gordon.
Okay, perfect. Are there any last questions here? I see there's a comment in the chat. So from Manuela, some considerations to exercise is exercise intensity, patient's exercise capacity, and levels of physical condition. And motivation is also an important marker, and lots of studies lack when reporting it. So, you know, similar to a comment made by Amit and Pavlos yourself as well. Exercise duration and progression is also a big thing. Yeah, I don't know, Pavlos, if you had any comments on Manuela's comment as well.
So what we did when we did the big network meta-analysis and the component network meta-analysis, we had the TDRL checklist and tried to describe the intervention components like exercise duration, progression, and all these things were missing. Not only missing, but if you go to the clinical practice guidelines, we have this strong recommendation for exercise, but they don't say all these things. So again, determining all these parameters for exercise are very important. And I agree with Manuela that, you know, what is the patient's exercise capacity can be very personalized compared to one versus the other, and how, you know, the healthcare professionals that can make the exercise, let's say, more personalized, because I can have different capacity, let's say physical activity levels or strengthening compared to other people, right? So we need to consider those things. As the motivation, again, that was an excellent comment, but from all the trials that I have seen in OA, and I have analyzed a lot, I'm not sure I have seen one in terms of reporting the motivation levels, or whether, or if they were asking whether the patients are motivated.
For sure. Yeah. Awesome. So I'd love to keep going, but I think we have now reached 2 p.m. Eastern Standard Time. So that is going to be the conclusion of today's session. So, a huge shout out and thank you to our presenters, Abby from this morning and Dr. Pavlos Bobos from just this session here. As far as the comments go, if there's any comments that we didn't get to from the chat, we'll go ahead and send those along to Pavlos as well, so you can take a look and reach out to the commenters as well. And we really appreciate everyone's participation, the panelists as well, all the audience members as well. This was a fantastic discussion. And we look forward to seeing you tomorrow for day 2, starting at 11 a.m. Eastern Standard Time for more expert conversations from Dr. Pavel Roshanov and Dr. Roni Karut as well. So have a great day, everyone. Thank you for your time. And yeah, if there's any other last comments, please put them in the chat and we'll send them along to our presenters. Thank you.
Thank you.